Welcome to this explainer, where we're diving straight into the ultimate biomachine, the human heart. Today we're exploring the foundational mechanics of cardiology, and it's just a fascinating subject because, well, the heart operates quite literally like a high-performance engine. Think about it. It relies on this incredibly sophisticated electrical wiring system to keep the rhythm, and a highly complex plumbing network of coronary circulation to supply its fuel. When both of those systems are working in harmony, it is an absolute biological masterpiece. But as we'll see, when just one part falters, the entire system is put at risk. Okay, so here's our roadmap for today. Number 1, the heart's electrical wiring. Number 2, decoding escape rates. 3, mapping coronary circulation. 4, when the wiring fails. And finally, 5, acute coronary syndromes. Let's get right into it. Section 1, the heart's electrical wiring, the heart's spark. Take a look at this master flow chart mapping out the cardiac conduction system. It perfectly illustrates how an electrical spark originates right at the very top in the sinoatrial, or SA node. From there, it travels down through the atrioventricular, the AV node, crosses over the bundle of His, and then branches all the way down into the Purkinje fibers at the very bottom. You know, this isn't just some random spread of electricity. It is a highly controlled, specific pathway designed for absolute maximum efficiency. Let's actually trace that electrical impulse step by step. Step 1, the SA node fires. That's your initial spark. Step 2, the AV node receives the signal and, well, it intentionally delays it. This microsecond delay is absolutely vital because it gives the lower chambers the exact time they need to physically fill with blood. Then, step 3, the bundle of His transmits the signal, acting as a crucial electrical bridge. And finally, step 4, those Purkinje fibers rapidly distribute the impulse out to the muscle cells, triggering that powerful coordinated squeeze that pumps blood to your entire body. Section 2, decoding escape rates, built-in backups. Now, this hierarchy right here brilliantly illustrates the heart's pacing. On the left side, we've got the SA node, which acts as our master clock. Under normal, healthy conditions, it reliably fires at about 60 to 100 beats per minute. But on the right, look closely at the AV node. Not only does it serve as the gatekeeper we just talked about, but it actually has its very own intrinsic firing rate of 40 to 60 beats per minute. It's essentially a built-in biological backup generator. So the big takeaway here, it's all about survival. If the primary SA node fails or gets blocked for some reason, that AV node automatically steps up to save the day at a steady, albeit slower rate. And get this, if even the AV node fails, the fibers further down the chain can actually fire at 20 to 40 beats per minute as an absolute last resort. It really is an incredible story of profound, layered resilience built directly into our anatomy. Section 3, mapping coronary circulation, mapping the plumbing. Let's transition from the wiring to the plumbing and build a geographic map of the heart. When a patient is experiencing a heart attack, the ECG leads act exactly like GPS coordinates. By analyzing which specific leads are showing abnormalities, we can pinpoint exactly which coronary artery territory is choked off. For example, if we see changes in leads I, AVL, V5, and V6, that tells us the left circumflex artery is compromised, which directly affects the lateral wall of the heart. To highlight a really critical example here, if we detect abnormalities specifically in leads V1 through V4, our GPS points directly to the left anterior descending artery, the LAD. Blockages in this specific area are notorious because they carry a massive risk of cardiogenic shock. So you see, the ECG isn't just a squiggly line on a page, it's a very direct, real-time window into the heart's hidden plumbing. Section 4, when the wiring fails, electrical breakdown. So what actually happens when the communication between that master clock and the gatekeeper breaks down? Well, this brings us to bradyarrhythmias, which are dangerously slow heart rhythms. These most often happen when there is a systemic failure, specifically an AV block. Remember that single electrical bridge we talked about? When signals get delayed or completely stopped right at that junction, the heart rate simply plummets, and your brain and your body stop getting the oxygen they desperately need. Check out the escalating severity of these blocks in the data here. A first-degree block features a prolonged but fixed PR interval, meaning the signal from the top to the bottom of the heart is just slightly delayed. It's generally pretty benign. But things get dangerous at the second-degree level, where you have a fixed interval before a suddenly dropped beat, which often requires a permanent pacemaker. And at the absolute extreme, that's a third-degree block. We're talking complete dissociation. The upper and lower chambers are totally disconnected, beating entirely independently, which demands immediate medical intervention. But conversely, What if the heart's wiring is racing completely out of control? That gives us tachyarrhythmias. To reset a rapid rhythm, we rely on highly targeted antiarrhythmic drugs. Think of them like specialized tools. Class 1 drugs are sodium blockers targeting oxygen-starved tissue. Class 2 are beta blockers, which help calm the heart's automatic firing rate. Class 3 are potassium blockers that prolong the reset phase between beats. And Class 4 are calcium channel blockers, designed specifically to slow down conduction right through that critical AV gatekeeper. Section 5. Acute coronary syndromes, a plumbing disaster. Finally, we have to talk about what happens when the coronary circulation is chronically compromised, like when a patient suffers from stable ischemic heart disease. The medical interventions here really boil down to basic economics, supply and demand. Beta blockers are a vital first-line treatment because they instantly reduce the heart's workload and its demand for oxygen, effectively protecting that starving muscle. We'll often pair this with long-acting nitrates to relieve painful angina symptoms, and sometimes calcium channel blockers to further ease the strain on the whole engine. To wrap up our explainer today, just take a moment to reflect on the sheer biological genius of this entire system. The human heart is designed with profound resilience, built-in backup pacemakers, and overlapping layered defenses. But really understanding these mechanics leaves us with a pretty critical question to ponder. Given all the incredible, elaborate fail-safes your heart has built in just to keep you alive, what are you actively doing to safeguard your own cardiovascular health today?